Welcome, and thank you for joining us today on this very busy season. My name is Pat Furlong. I'm with Parent Project Muscular Dystrophy, and today we're going to talk about the heart of the matter. I think you've been seeing our mails and seeing our interest in heart disease and Duchenne and in their carrier moms for many, many years. So today we're being joined by May Ling Mah, Kan Hor, and Dr. Lee Sweeney as well. So just a little bit about them. Dr. May Ling Mah is dual-trained in internal medicine and pediatrics with a subspecialty certification in pediatric cardiology and adult congenital heart disease. She's currently a staff cardiologist at Nationwide Children's Hospital, and she specializes in clinical work with a focus on adult patients and echocardiography. She's active in the research in the environment, and I'm sure many of you have seen her in the adult clinic talking about the Carrier study that's going on at Nationwide, so in Carrier Cardiomyopathy. Kan Hor is a pediatric cardiologist at Nationwide Children's in Columbus, and he's the director of the Cardiac Magnetic Resonance Program, focusing on the care and improved diagnosis of cardiac disease for patients with Duchenne. He's involved with evaluating cardiac function in multiple clinical trials and is working to develop a natural history database for cardiac disease in Duchenne. He uses MRI. Lee Sweeney is the Thomas H. Marin Endowed Professor of Pharmacology and Therapeutics at the University of Florida and Director of the UF Myology Institute. Dr. Sweeney is working on developing therapies for rare diseases, for sure in Duchenne, that include both small molecule and gene therapy approaches. He serves as a consultant to a number of industry therapeutic developments, and he is PPMD's Director of Research. So today we're going to start off talking about carriers and the risk they have for heart disease. So I'm going to turn this over to Dr. May Ling Mah, and she'll talk about the carrier study going on nationwide. May Ling?
Thank you, Pat. The name of our study is actually Incidence and Prognosis of Clinically Significant. It's cardiac, neuromuscular, and psychologic disease and carriers of Duchenne and Becker's muscular dystrophy. We're going to, given the time, we'll focus on the cardiac findings so far. This is our year one data, and so the process of the study is that we have completed all of the year one recruitments, or haven't completely completed them, but we're getting close to kind of finishing year one to the point where we're able to analyze some data, which is the exciting part. We have actually reached completion with a few of the women, and they've completed their year three data, and so it's a rolling study that continues to be ongoing. So the participants in the data that I will show you today include moms with DMD and BMD-affected sons. All of the women were genetically confirmed. 57 of them were identified as carrier moms, and 20 of them were non-carrier moms. If you were in Arizona with us, I referred to them as somatic and non-somatic, and as I started kind of writing the paper for this, it occurred to me that that gets very confusing. So a carrier mom is somebody who is found to have a genetic defect in the Duchenne's region, or that is contributory to Duchenne, and a non-carrier mom has a child with Duchenne or Becker, but did not have a genetically proven defect. And so all moms with boys, but almost 60 of them had genetically proven defects and 20 of them did not. We also enrolled 25 healthy control moms, and so these were age-matched moms. Two are moms of boys with DMD. The average age in all of the groups was 42. The range was between 28 and 63. And did not differ between the three groups, and so it wasn't like we had a much younger control patient population or carriers were older or younger, either one. So we felt that they were comparable groups to look at. So this study is different, and I think in large part this is completely to the credit of PPMD for sponsoring such a large study on carriers. And so this is by far the largest case control study of carriers, and looking at them, again, I'm presenting just the cardiac portion of it, however, looking at them in all facets. It's a longitudinal design, and so the anticipation is to get 3 to 5 years of data, and then also look at our control population for normal parameters. Not a lot of normal, healthy women are getting treadmills and MRIs, and so just knowing what was normal was helpful to us, and actually it was incredibly helpful when we started looking at the data. This is a holistic look at the patient. So it's necessarily interdisciplinary, and I'll kind of nod to that at the end, and we'll talk about correlations within the cardiac study, but I wanted to make clear that this is a much bigger study with many more people involved here at Children's than just Kan and I. Treadmill testing has not been done in carriers, and I think it's a beautiful way to kind of test function, like what actually can you do. A picture is a picture, no offense to Kan. So, you see what you see, but the reality of it is the people you are more important to us, and so treadmill testing became an important facet of this we definitely wanted to include. We weren't sure what we were going to find, but including it we felt was going to be important. And then there are technical improvements. And so the backbone of imaging is cardiac MRI. Novel techniques, which are lessons from your sons, have been incorporated into this study so that we know kind of what to be looking for in Duchenne and specifically with MR. So what makes a mom a carrier versus a non-carrier? And so, DMD and BMD have both been defined genetically. So some moms are genetically proven carriers, and so therefore I will call them carrier moms for the rest of this talk. Some moms do not carry a gene causative of DMD and BMD in their sons, and so those will be referred to as non-carrier moms. Not all carrier moms are equal, and we know this by other studies regarding X chromosome inactivation. And so all women have two X chromosomes, and one of them would be abnormal, and one of them would be normal. And it just depends on how much of each of those X's you express. And in all women, that's a very complicated process and is different. And it turns out it's different even kind of mother to daughter who have the same gene defect, or they may or may not express it in the same way. There are several families involved in this study, and I think that should be a separate look, because I think this is also a very important question. So the starting line. So this is step one. We're really looking to define disease prevalence and severity. So how frequent is cardiac disease in carrier moms, and how severe is that disease? We have to have this knowledge to determine the need for treatment, and I think everybody is clamoring at the idea of we have to do something about this, and I completely agree with that. But knowing exactly what the disease is going to help us, I think, more than anything in terms of the step two. This also lays groundwork in terms of determining the type and timing of treatment, as well as how to monitor efficacy. And so I think what's become clear, and I'll present a little bit of this data today, is that echo is no longer the way to diagnosis. It becomes MRI, and then at that point when you start treating, then now we know how to look for disease. And so all of this is kind of groundwork, and I think really kind of foundational to moving forward. So here are questions. So the questions kind of that I'm going to try to answer in terms of our year one data is, does carrier cardiomyopathy exist? If it does exist, how prevalent are its manifestations? And then what does it look like? So very basic, but fundamental. So this is what we thought we knew. And so this is kind of a conglomeration of quite a few studies, and that, it has been recognized that carrier cardiomyopathy increases with age. It is often felt to be the only manifestation in regards to the neuromuscular findings that we see in the boys. The cardiac disease seems to be kind of the hallmark and what really needs to be followed in terms of a potential pathologic entity. And when you look at it, I told you our patient cohort is kind of, the sweet spot is about 42, so that was the average age. But if you look at the age range here of the 31 to over 50-year-olds, which are essentially comprising most of our patients, they're really reporting out kind of 9 to 15% cardiac disease. And this is not the case. And I think that in large part a lot of the studies were underestimating it, because a Duchenne's mom was considered a Duchenne's mom, and it did not matter if you actually carried the gene defect or you did not. And so what this is it's an aggregate number of, if I were to look at all of the women, almost 80 women, and completely throw out their genetics, these are probably the numbers we would have come out with. And it just really the number you could make it anything, depending on whether you recruited women who are carrying the gene defect or women that weren't carrying the gene defect in terms of your patient population. And so that's why we were getting vastly different kind of numbers, right? And so in this study, we're hoping to kind of really clarify it. If you have the gene defect, here is your risk. If you do not, here is your risk. And so, and the other thing is the modality was different. And so much of this was all based on echocardiogram, which was kind of standard of care at the time. It's what you had in 1999, and so I think that that's a reasonable thing. But we obviously have better ways to do that now. So answer one is yes, carrier cardiomyopathy does exist. So this is certainly isn't earth-shattering. I think everybody on this call would recognize that was probably going to be the answer. There are treadmill differences, and so one of the things that was remarkable is that I was seeing arrhythmia differences, and this certainly was not something we were expecting kind of coming in, something I happened to get while we're doing a standard treadmill. What I was seeing is premature ventricular contractions. So when your heart beats, you start at the top chambers and then you beat the bottom chambers, and if instead a part of the heart decides to be irritable and the bottom chamber decides to beat first, it's called a premature ventricular contraction. Usually, when you only see one of them, it does not mean anything clinically. However, it can be considered a marker of irritable myocardium. It is seen in carrier moms in the early recovery stage. So actually not during the treadmill. I saw them during the treadmill, but what really seemed to happen was as soon as they stopped the treadmill and they were kind of resting or doing that slow-down walk, that's when I really started to see them. This is very different than what we saw in non-carriers and controls, and it did correlate with fibrosis on the MRI, and I'll give you some of that data as we go on. So MRI fibrosis was also different. So fibrosis was seen in 50% of carrier moms. So it was very different than the 15% that is reported kind of previously. So out of the women who had genetically proven Duchenne lesion, 50% of them showed us fibrosis on their MRIs. One non-carrier mom had fibrosis, and what will be interesting with that patient is as we follow her forward, whether something will be identified in her or whether she progresses differently. And none of the controls had fibrosis. So there was a pretty high prevalence of manifestations. So the percentages that I had were in terms of people who had these premature ventricular contractions on treadmill. About 25% of the carrier moms showed me that. One of the non-carrier moms showed me that. Unfortunately, it was not the same non-carrier mom that had fibrosis on MR. That would have been a nice kind of correlation. So they're actually two different moms. But one of the non-carrier moms did show me this PVC pattern in recovery and none of the controls. In terms of fibrosis, it was kind of, it depended on kind of how we included the sample, but it was 44 to 50%, and then one non-carrier mom. So when we correlated it, so the VE recovery is the ventricular ectopy recovery, and so this is what I was using as the tagline to say you had these early beats in the recovery stage. We were able to predict that the patient would have MRI fibrosis about 70% of the time, so that wasn't so bad. So if I saw this during your treadmill, I could say, I was right, 70%. That was my hit rate. Specificity was also pretty good, and so what that means is if I had a negative treadmill, about almost 90% of them were truly negative by MRI, and so that wasn't so bad. And so in terms of correlations, this one particular finding of arrhythmia could help you stratify in terms of as a carrier, where are you going to be? Are you going to be in that 50% with or 50% without? And so treadmill ended up being actually a quite nice kind of non-invasive way to kind of screen for that. So what does it look like? And so this is a bit of better news in answer two. So it doesn't look so bad. And so, I've given you our abnormal findings, and I think it's important to give you what the normal findings were. So functional capacity, so how much energy your heart, lungs, muscles, and blood vessels give you to exercise. And it's one of the biggest things we test in treadmill testing. This is not different between carrier moms and non-carrier moms. There was a very slight difference that we were attributing to deconditioning, but when you normalize for everything, it actually was fine. And so within a normal range, very similar to controls, and so your heart wasn't really limiting you. And so even though we were seeing these markers that could potentially mean you had fibrosis, it did not limit any of the women in comparison to controls. In terms of the MRI findings, heart sizes were within normal limits for all groups. Average left ventricular ejection fraction was also normal. And so even though the carrier moms were slightly lower in terms of ejection fraction, we're really talking about 59% versus 62% ejection fraction, with 60 being normal. And so you can see that the carrier moms, even though they had fibrosis, the function was still preserved. So this is not a clinically important difference, and so it would not kind of account for any heart failure, certainly. And only 5 carriers had abnormal ejection fractions, and so I used anything less than 52, we would consider you were abnormal, and all of those women had fibrosis. So I think fibrosis is an earlier marker. Drop in ejection fraction comes later, and obviously our sample is kind of middle-aged, and so we'll have to see how this progresses as well. So next steps, years 2 and 3 are in process, like I said. Age clearly matters. When I looked at the patients who had kind of the arrhythmia during treadmill versus those who didn't, the age was older. All pretty close, though, and the same thing with the fibrosis by MRI. The average age was older in the women who had fibrosis versus those who did not. So stress biomarkers were elevated, and so our next steps are actually to take our cardiac findings and then connect them to Jamie Jackson's work in regards to the stress to see whether women with higher stress levels had a greater propensity for fibrosis. So the take-home message should be, I think, that genetic testing is imperative in moms of boys with DMD and BMD. It is a clear cut. Where if you do not have the genetics as a carrier, then your risk goes exceedingly low. If you do have it, then you need to be followed. So while manifestations are clearly evident, carrier moms on average are doing well. Ejection fractions were preserved, heart sizes were pretty good, and again at an average age in the 40s. The ejection fraction decline trails fibrosis, and so your ejection fraction is preserved for longer, and it seems to be a later finding in carrier cardiomyopathy. I think, based on the study, we would probably recommend MRI kind of in that fourth decade in terms of being able to pick this up, in terms of picking up the fibrosis. Echocardiogram would then no longer be the perfect test, because if the ejection fraction doesn't decline until much later in a fibrosis course, then perhaps we've missed a window of opportunity for treatment. Exercise testing may have an important role in predicting future risk of cardiomyopathy, and these ventricular ectopic beats in recovery may be a promising predictor for fibrosis by cardiac MRI. So this gets around to one of the practical questions about what if I can't get an MRI? Well, a treadmill test is pretty inexpensive, and it's actually not that hard to get and fairly universally done. So I have to acknowledge kind of PPMD for sponsoring the project. Nationwide Children's Heart Center Research Program also provided the funding to test the controls, and so clearly none of this was possible without these two groups. And then this is the greater group that I had alluded to before. Pat Furlong stole our excellent research coordinator, so I have to add we do have a new research coordinator, and it's all PPMD's fault. He's a wonderful guy, but we do. I put his name on this slide should any of you want to contact him about this study. So I'm open to questions. I do have to leave in a little bit here, but I'm open to questions if anybody has any.
If there are any questions, please post them. And May Ling, yes, we did steal Eric Camino.
I know. So. I'm still bitter about it. Can you tell?
You can't be bitter about it. He's still in the family. So
perfect.
We didn't let him leave the space, so that's very good. So, May Ling, just a question for you is, I know that you've looked at any number of parameters, and when do you expect that we might see some of those, at least first learnings from those?
In terms of publication?
Yeah, in terms of publication
so I've written an abstract. The abstract went to the American College of Cardiology. I think I sent that out a month or two ago, and right now we're writing the manuscript, and so we're going to put that together. I think Kan and I, our parts are okay in terms of correlations, and then we would really like to add the stress piece in prior to writing the bigger paper. And so, my goal for it is actually this spring to have a full paper on year one data. The longer study, it's going to be about another probably year or two before we finish all of the collections, or maybe even a little longer. But I think year one data looks good, and I think we can probably publish it soon.
Good. I think we're all concerned, right, about stress in terms of these families and caring for young men and some girls with Duchenne, and how we respond to that and how we might make sure that our lives are the best they can be and take care of ourselves. So I really thank you for that. It's really a wonderful project, and we're very excited to be a part of it. So thank you for that, May Ling, and we won't steal any more of your people at the moment. And so now we're going to turn to, and thank you very much, May Ling. I know you have to go. I appreciate your participation today. So we're going to turn now to Dr. Kan Hor. Kan's going to talk about, as you know, and you've heard in this community, I think Linda Cripe was one who really was pushing for cardiac MRI many, many years ago when there was some concerns about, is that useful? How is it going to be useful, and what are we going to learn over time? So Kan's going to talk about that and understanding the cardiac MRI and what we can learn from it and how we can think about it in the future. So Kan, I'll turn this over to you.
Okay, thank you, Pat. I really appreciate the opportunity working with you now for more than a decade, and I think these type of webinars have been really important to be able to share information that we all learn. Can everyone see my screen?
Yes, we can.
Okay, perfect. So I'm going to move forward with this. So really, why should the heartbeat in DMD be a major focus of care? I think the answer is that DMD-Associated Dystrophin cardiomyopathy is the leading cause of morbidity and mortality in patients with Duchenne muscular dystrophy. So let's kind of step back a little bit, and what does cardiomyopathy mean? So cardiomyopathy is disease of the heart muscles. You have on the left side here a normal functioning heart, and then the right side where you have changes that become dilated and dysfunctional, and it goes through a cascade of muscle cell injury, chamber dilation, wall thins, scar formation, and ultimately function declining by ejection fraction, and then what you get is heart failure. Heart failure is a complicated mechanism. In essence, the heart fails to meet the needs of the body. Now, it does not mean the heart has failed, stopped working. It occurs when cardiac function is poor, but can occur with good function and increased demand. The body's response, as you can see in this cascade, first is helpful, but eventually causes harm. So there are ways that the American Heart Association has looked at traditional heart failure symptoms, which include shortness of breath, chronic cough, wheezing, fluid buildup, fatigue, lightheadedness, nausea, lack of appetite, confusion, impaired thinking, high heart rate. Some of these are not very specific and are sometimes really tricky, especially in our patients. So one of the ways people look at this is the New York Heart Association classification for heart failure. And it's based on heart failure symptoms and functional limitation is divided into 4 classes. So I've highlighted the area that's important here. So the 2-mile class, class 1 and class 2. Class 1 is without any limiting physical activity and anything you do. Class 2, you have some slight physical activity, you're comfortable at rest, but when you start doing activity, you start to feel bad. And class 3 becomes more moderate, where you start having marked limitations of physical activities. And you're comfortable at rest, but you can't do much of things without having shortness of breath. And then class 4 becomes very severe, where you really can't do any activity at all, including your daily activities of living. So this becomes a little complicated. So the American Heart Association and American Cardiology in 2001 developed a slightly different rating system that I think is a little bit better for how we can apply to our patients for progression of heart failure symptoms. So I'm going to take what they say and I'm going to put us in terms of Duchenne population, what that means. So the 4 stages of heart failure. Stage A is presence of heart failure risk factors, but no heart disease and no symptoms. So people with diabetes, high blood pressure are at risk, but they don't have symptoms yet. In Duchenne, in DMD and BMD, you have dystrophin deficiency. That's your risk. Stage B is heart disease is present, but there are no symptoms. So there's some structural changes before symptoms occur. So in DMD, you have scar formation, but your heart function becomes normal. As you know, our boys do not have heart failure symptoms like traditional adult patients with heart failure. And then stage 3 is when you start having some structural changes that is present and symptoms can occur then. So in DMD, you have more scar development. The number of scars starts to increase substantially. That leads to abnormal heart function with abnormal ejection fraction. And then stage 4 is when you have presence of advanced disease with significant symptoms despite aggressive therapy. So in DMD, you have progression of scar, progression of dysfunction, which now becomes severe range, which to me is a stage where you really can't do anything with. So these classifications have driven clinical practice in traditional heart failure treatment, and trials that frequently include use of these classifications. Now, neuromuscular disease such as Becker and Duchenne muscular dystrophy universally develop cardiomyopathy and heart failure. The time course is variable, of course. And the problem is that the boys do not have symptoms. They cannot tell you they have shortness of breath because of skeletal muscle disease. So the utility in neuromuscular disease, in particular DMD, is limited. Skeletal muscle disease limits its utility as our boys are not able to, because of loss of muscle mass and loss of muscle strength, are not able to do the activities that traditional heart failure patients are able to do. And in fact, DMD patients lack traditional heart failure symptoms even in advanced disease stages of heart failure. So in looking at DMD-Associated Dystrophin cardiomyopathy, in the past, the clinical course was characterized at a time when imaging was really less sophisticated. So cardiomyopathy does not manifest until late teens, is what I learned when I was young, when I was in early training. We can't see it must not be there. Now what we know now is that the myocardium is dystrophin deficient. Cardiac disease is present at birth. As you know, the CKs are abnormal. ECG is abnormal at birth with high heart rate. And disease progresses with time and is best assessed by non-invasive imaging. Why? Because cardiac disease is a significant contributor to disease-related morbidity and mortality. So what do we believe? Well, we believe that therapy does offer hope. If we have to impact disease, we need to intervene early before irreversible damage occurs. These are lessons in both skeletal treatment with steroid and respiratory care with ventilation. You have a normal heart function here, and you want to start treating before dysfunction when you have a lot of scar formation, as shown in the white area here in the pathologic specimen and in the blue area. These are scar formation. So we know that therapy offers hope. over the last 20 years, corticosteroid has slow progression skeletal muscle disease. Respiratory care has improved survival. Now we're dealing with the leading cause of death is from DMD-Associated cardiomyopathy. So until more recently, most patients come to cardiology quite late in the disease course. So really, what you need is a proactive approach, and I have to credit PPMD and Linda really for leading the field in terms of getting patients into the cardiology clinic. What we want to do is enhance quality of life, prolong duration of life, stimulate research to change the cardiac outcome, improve quality of life, and really improve evidence-based practice. So what is this evidence? I think the evidence of DMD-associated dystrophin cardiomyopathy is best understood by cardiac MRI. So the rest of the slides, I will hopefully show you some of this evidence to help give you a better picture. So the advantage of cardiac MRI over other methodology is that you can look at function by ejection fraction accurately. You can look at scar formation by LGE or fibrosis. And then there are some newer techniques, which I'll talk about myocardial strain briefly, but there are other techniques that we won't talk about, but can play an important part in the disease process. So ejection fraction, as you can see here, is by cardiac MRI measures the global state of how well the heart squeezes, as the heart fills and squeezes. So we know that looking at this graph here, function by age over time, this is published by one of our fellow Dr. Tandon here. We know that cardiac function by ejection fraction declines over time. It's worse with age, as you can see by the red arrow, with age being on the x-axis and ejection fraction being on the y-axis. And you can see here in looking at the preliminary data from our PPMD grant here, looking at a large data set that we have, you can see that by all the ages from age 6 to age 20, you can see that ejection fraction abnormality starts around age 10 and becomes much more common with age, as shown by both graphs here. Now, what do we know using cardiac MRI? Well, cardiac MRI can track function by ejection fraction over time. It provides a mean to assess cardiac disease progression, provides the ability to assess therapeutic efficacy, and provides a mean to determine natural history, disease modeling. What are impactful things that we find in MRI that can help stratify the disease better? So ejection fraction, the currently gold standard, is used in Duchenne assessment. It's used in both adult and congenital heart disease to look at global function. Unfortunately, ejection fraction, especially in Duchenne, is a late finding in the disease process when the heart no longer squeezes normally. So the question has always been, are there ways to look at DMD-associated heart disease beyond squeeze? And fortunately, there is. So I'm showing you here, looking at squeeze, beyond squeeze, which is by myocardial fibrosis scar imaging here. You can see here in this panel in the pink area here is the bright area within the pink circle here on the outer edge, and then on the pathologic specimen, the white area, and then on the blue area in the histologic specimen. It's called subepicardial region here. This is in comparison to patient with heart attacks, where it's surrounded by the red. It's on the inside part of the muscle called the inner surface, but the same type of imaging on MRI. So we first published this paper back in 2007. We typically have not done scar imaging when we first started this, only did in older patients, but we actually managed to have some younger patients that underwent scar imaging, and we found that fibrosis was associated with ventricular dysfunction, but we found that few patients with fibrosis actually had normal function. So as a result, we started recommending having all patients get IV imaging. And I think to credit to the moms and the boys, they're willing to go through this. And I think this next slide shows you the importance of this. So you can see here in the top panel is no scar. Everything looks really nice and black here. And then here's a subset of here with some scar here, but normal heart function. And then you have a lot of scar formation here. You can see up here you have 17% of boys less than 10 years of age have scar, with the youngest being about 6.5 years of age. When you're between 10 to 15 years of age, 34% of boys have scar. And by the time you're greater than 15 years of age, upwards of 60% of the boys have scar. And this is taking all comers age alone. Well, let's just say if you get age and look at heart function. So 30% of boys with normal heart function have scar. And by the time you have abnormal heart function, more than 84% of boys have scar. So really, scar formation comes before ejection fraction abnormality. And this is a really nice scatter graph here of a total about 300 patients here. You can see that myocardial fibrosis, the red square, is where patients have scar, and it is more common in patients that are older with abnormal heart function. That's not very surprising in the disease process. Now, what's very striking is that that myocardial fibrosis is a precursor myocardial dysfunction. You can see here that in the younger age group, less than 10 years of age, with normal ejection fraction here, you see a bunch of red. These patients are young with normal heart function, but yet actually have scar. So this really helps seal the finding that myocardial fibrosis is an early finding of DMD-associated dystrophin cardiomyopathy. So when you look at scar imaging over time, so patients with myocardial fibrosis or scar have worse ejection fraction over time. So the number of segments of scar you have, the worse your ejection fraction over time here. And then the older you get, the more patients that have scar, which you can see here by this other graph here. So now we're going to move into how do you better look at the heart's contractility beyond squeeze. Remember, ejection fraction is just how the heart squeezes, and it's a late process. So we need a more sensitive method beyond squeeze that can detect cardiac dysfunction earlier, and this is called myocardial strain. So I'm not going to spend a lot of time on this. It's technically complicated, but myocardial strain is looking at deformation or shortening of an object or muscle relative to its original length. It gives information on myocardial strain. So this is a special technique that truly looks at the heart muscle contractility beyond what ejection fraction can tell you. So why use strain? Well, detection of disease early will allow better understanding of the disease mechanism and shift the paradigm from prevention to rescue. Sorry about that. So here, we published this in 2009. We show that circumferential strain is abnormal. So the lower the strain, the worse it is in young DMD boys less than 10 and boys older than 10, despite completely normal ejection fraction. No difference between control and the patient. And then it works when you have fibrosis, some dysfunction, and then it gets even worse. So the strain continues to decline with age and disease progression. And this is a really important piece. And then we also looked at over time. So we have about 50 patients we looked over time. We found that in the red here, every single patient had decline or stability in myocardial strain over time. On the other hand, you actually have about 38% of boys actually had improved ejection fraction, that's in the blue here, despite no change in medication. This just tells you in a progressive disease, the ejection fraction is not sensitive enough to detect these changes. So when we put this together, what are we learning from cardiac MRI? Well, it provides evidence of cardiac disease in a population with no routine way to assess heart failure symptoms. It provides the potential to create markers of disease before the heart no longer squeezes normally. It provides a means to assess therapeutic efficacy, and really provides a way to model data to model disease, which PPMD is funding us to be able to do this, and we are actually quite close to completing the data collection. So let's kind of put this together, and how do we understand cardiac MRI? Can we use this knowledge to better characterize and stage DMD-associated dystrophin cardiomyopathy? The answer should be yes. Cardiac MRI then should be routinely used in clinical practice when the boys no longer need sedation, which is around age 6 to 7. And then in any drug trial that involves concern with cardiac effect. Cardiac MRI is vital in staging cardiac disease, since DMD boys lack traditional heart failure symptoms, and current markers of the disease are not sensitive enough. So can we modify the ACC-AHA heart failure staging in DMD using cardiac MRI? The answer is yes. The rationale is because DMD patients lack traditional heart failure symptoms, and heart failure classification schemes are not useful to dictate where you are in your disease process. So here's my proposal. This is so you have stage 1 here in DMD dystrophin cardiomyopathy. You have no scar, but you have dystrophin deficiency. Normal heart function by ejection fraction greater than 55%, and you have abnormal myocardial strain magnitude, which is less than 16%. Then you develop in the stage B, where you start having some scar, but less than 50% thickness, and of 16 segments that's divided by what they call AHA 16-segment model, you have at least less than 16 segments that are positive scar. Heart function still remains normal, but myocardial strain continues to decline to less than 14%. And then you become stage C, when you start having overt disease by MRI. The scar becomes much more prevalent with greater than 50% thickness in many of the segments there. And then you start having at least more than 6 out of 16 segments. And it involves the apex of the heart, the tip of the heart, and the septum. And then you start seeing abnormal heart function by ejection fraction of less than 55%. Abnormal myocardial strain then becomes lower in 12. I didn't give you stage D. I think stage D progresses even more, but I think we don't want to get to that point. So I think this is a better way to look at this, right? So I kind of create this curve to try to get a visualize in this. Heart rate remains high through the stage. So stage A, abnormal strain, no scar, LVEF greater than 55%, fast heart rate, no heart failure symptom. Then stage B, you start having abnormal strain going down. Scar formation is seen less than 55% with less than 6 out of 16 segment. Ejection fraction by MRI remains normal. Patient maintains fast heart rate, but still no heart failure symptoms. And then stage C, you start having worsening strain magnitude. Scar becomes more with greater than 50% thickness, and you have more segments that are affected. Then you start seeing abnormal ejection fraction as shown by the red here. Heart rate remains fast, and you might have some vague symptoms that may not necessarily be related to heart failure. So in really conclusion, with addition of new techniques such as T1 mapping, extracellular volume, ECV, this may further refine staging. I think future study needs to confirm the staging correlate to outcomes including morbidity such as hospitalization, mortality. The future needs to be now, and the surrogate cardiac MRI marker is vital to not only understand and better characterize cardiac disease, but to assess treatment efficacy to ultimately prevent dystrophin cardiomyopathy with all the drug trials that are going on now. So I really like to thank all the patients and family over the last decade that just really have come and just be willing to go through the process here, and many colleagues across the country, and really in particular PPMD for sponsoring many of the things that I do, including the natural history study that we're doing now. And then the Heart Center has given me some money to use to look at some technical study, and then Duchenne Connect with the Duchenne registry will play an important part in tying the MRI to the clinical information. So I'm not sure how far we're on time, but I will end with any questions that are urgent. If not, we can do it at the end.
Thank you, Kan. That was really terrific. I have two questions for you, and one of them is I think that it's something that rolls around in my mind a lot, and as drugs are extending function and young men and are walking longer and longer into their teens, do you think that the heart is built to last? Will that extended function in terms of skeletal muscle cause more burden on the heart?
Yeah, so I think that's an important question. I think, you do, I think when you stress the heart is going to work harder. And if for someone who's walking and doing more normal daily activities, you're certainly stressing the heart more. And in a dystrophin deficient heart, I think there are risks for that. So I think it's important that we can't treat patients by single organ system. I think a patient needs to be treated as a whole person. I think that's kind of the holistic approach to studying patients is really important. I think all the therapies we do needs to address really the whole patient. And I think the cardiac, your question is a very important one. I would believe that is a risk.
Thank you. And my next question, and then we'll give the slides back to Lee Sweeney. My next question is Kan, if your son was diagnosed with Duchenne, how early would you initiate ACE inhibitors, beta blockers, ARBs, and what would you initiate and when?
Yeah, I think it's a great question. I worked with Linda quite for a long time, and I think the question is that, this is a lifelong treatment, so starting too early can have some of the side effects, as we know, in some of the developmental things that are studied based on the neurohormonal pathway. But I think at some point, I think using cardiac MRI will help with this. I think the moment you have scar, that's a good way, and this is how we've been doing our treatment. That's changed how we treat. I think using evidence-based data, having scar equates to disease. I think as we get better, with better treatment, including gene therapy, you may start going earlier because you get into the preventative route. So I think at this stage, the age roughly around 10 is still a reasonable age process. I think going younger, you need some good data to support that. We do treat patients that are younger when they have scar. I think that's kind of been our practice, but that's a great point, though.
All right. Thank you very much, Kan. We so appreciate your help today. And with that, I'm going to turn over to Lee Sweeney, who's going to talk about gene therapy and what we might do to preserve and protect this heart. Lee?
Okay, thank you, Pat. Can you hear me all right?
I can, yes.
Okay, so I do want to talk about gene therapy and the implications for the cardiomyopathy, as well as I want to start with really sort of giving you a little more background about why dystrophin deficiency in the heart really in some ways is a slightly different disease than in the skeletal muscle, and because of that, the treatments have to be somewhat different than what we're doing for skeletal muscle. So, So this is a slide that probably many of you have seen that I've shown many times. talking about the role of dystrophin in skeletal muscle and pointing out that its main role is this mechanical role. And so without dystrophin present, the muscle cell gets membrane ruptures that allows calcium and other ions to flow in, which ultimately leads to sort of a breakdown of the muscle. But it's been proposed in skeletal muscle and in the heart that also the lack of dystrophin, because of its organizer role, causes displacement of ion channels, and in skeletal muscle, nitric oxide synthase, and other things that should be part of the complex are no longer sitting at the membrane. So our underlying hypothesis, and we're trying to do more and more experiments to support this, is that the mechanical role really is the main role in skeletal muscle. And so most of the damage that drives the skeletal muscle disease is because of the loss of this mechanical transmission of force via dystrophin. But we think the organizer role is the more important role in the heart. And when dystrophin is not there, the cardiac cells can't properly regulate a variety of ion channels, especially the stretch-activated channels that are found in close opposition to the dystrophin complex. And so the mechanical role of dystrophin does exist in the heart. It's partially compensated to a greater degree by a more increase in utrophin in the heart than you see in skeletal muscle per unit mass of tissue. But also, I think the lower forces in the cardiac cells make that somewhat less of a problem than it is in the skeletal muscle. But the leaky ion channels, this dysregulation of ion channels, becomes a major problem for the heart. So that sort of leads us to the hypothesis that we're testing is that for the DMD heart, maybe the best targets are really trying to correct the perturbations in the calcium handling that come in part because of these leaky channels, and partly because of, and also address the mitochondrial dysfunction and loss generation that occurs later because of this constant calcium overloading of the heart. So the first sort of proof of principle study we did along these lines was really trying to address this calcium leak with the drug tadalafil. Many of you remember tadalafil because Lilly had it in trial. Lilly had it in trial to try to increase the blood flow to the skeletal muscle. So what tadalafil or sildenafil does is to inhibit the breakdown of cyclic GMP by inhibiting PDE5, which is the enzyme that breaks down cyclic GMP. When cyclic GMP levels are up, in the smooth muscle, it leads to relaxation of the smooth muscle and increased blood flow to the skeletal muscle. In the heart, what we were interested in was not that, because it really doesn't have a big impact on blood flow in the heart. But in the heart, the fact that you can also raise cyclic GMP levels by giving a PDE5 inhibitor has the impact that you get phosphorylation of some of these stretch-activated TRPC channels. And we think, and the postulate was, that's the major source of the calcium leak, and therefore if you could phosphorylate these channels, it will silence them. Even though dystrophin's not there and they're not normally regulated, phosphorylation still tends to close these channels. And so it might give a way, in the absence of putting back dystrophin, to try to lower this leak. So we looked at this in animals. We started treatment relatively late, and this, as Han just told you, and it's true in the animals as well, you get really progressive fibrosis before finally you start to see a fall off in ejection fraction at about a year of age in these animals, and then it's progressive. But we wanted to start the treatment at about the time that their ejection fractions were poised to begin falling, to see how much improvement or slowing of the disease we could see at that point. So we gave these animals tadalafil starting at 9 months of age, just before they would go into that decline, and then stop the study at 25 months of age. As Tom was telling you, we did cardiac MRIs on the animals, just as he does in people, and one of the early signs that there's a cardiac disease is this abnormal strain, as he said. And so we looked within the first few weeks of administering the tadalafil to the animals, which are the gray bars, the dark bars, and could see improvements in strain, trends in all segments that on the whole was significant, even within this very short period of time, but presumably because now we're trying to block this calcium leak, which is improving the calcium handling in the heart and improving the strain in the heart. We went on to show that at an intermediate time point at 18 months of age, when ejection fraction would normally be down, again we're seeing improvements in many segments, but then we lose this as the animals get older. The same thing is true of ejection fraction. This is actually fractional shortening from which we calculated ejection fraction. This was actually by echo. Here you see that we have pretty well maintained ejection fraction in the tadalafil-treated dogs up to almost 21 months of age before it starts going down, as opposed to going down. And now this is time after treatment, so this is this is now 18 months of age, and you can see in the absence of treatment we've had a significant decrease in the fractional shortening. And this, if you calculate ejection fraction, you can see that now the ejection fractions have gone down, whereas they're maintained on the tadalafil. What I had meant to put on this slide, and I realized just before we started I hadn't, was to show you that there's remarkably less fibrosis on the treated hearts than the non-treated hearts. You can see the lack of fibrosis here, and somewhat more, but still not very much in the right ventricle. It's the purple staining. But what I didn't put on this slide was the untreated, which have a tremendous amount of fibrosis. So it had a big impact on limiting the fibrosis, as well as improving the contractile characteristics and the blood flow characteristics of the heart. And what we saw when we analyzed the tissues, indeed we had decreased the relative amount of these TRPC channels and increased the phosphorylation levels. And so we were silencing these channels, and when we looked to see what else was happening besides silencing these channels, we saw that levels of M-calpain, which is a protease that's activated by calcium influx at the membrane, is down, also consistent with the idea that we're silencing this calcium leak. But interestingly and unexpectedly, we saw a major increase in the utrophin levels. And we think this is because calpain is the enzyme that breaks down the troponin. And so by not activating calpain, we're sparing a lot of the troponin utrophin that's being made. And so the utrophin levels are much higher in the treated heart. And so this is putting back some of the mechanical leakage. This won't silence the channels because you need dystrophin, not utrophin, to silence these channels, but it does give you more mechanical stability. So we got two benefits from the drug treatment. Looking at human hearts, we also see elevated M-calpain activity, and we see increased utrophin over control hearts. And the idea would be if you could use something like tadalafil to silence the TRPC channels, you could probably still get more utrophin in the human hearts as we saw in the animal heart. So that's just a summary of that data. But then what does this mean for gene therapy? So gene therapy for DMD is ongoing, as you know, and it's ongoing at several trials. And right now they're all using these microdystrophins. And the idea is that a high level of microdystrophin will get back a lot of the mechanical linkage in the skeletal muscle and greatly slow the disease progression in the skeletal muscle. And so it'll be, making the Duchenne patient skeletal muscle more like Becker patient skeletal muscle, and maybe on the milder end of Becker. Now, the problem, and this is where the Becker patients are really instructive as to the cardiac disease, many of the Becker mutations that result in fairly mild skeletal muscle disease can also result in fairly severe cardiac disease. So that tells us what the underlying hypothesis we started with is there are regions of dystrophin that are important in the heart that are not so important in the skeletal muscle. And so you might have deletions, in-frame deletions in a Becker patient that result in a more severe cardiac disease than skeletal muscle disease. So what does that mean for gene therapy? Well, for gene therapy, and this is now a study from Dongchen Duan, this was not done with gene therapy, this was done transgenically, but it illustrates the point that he put in a fairly large dystrophin construct, larger than the microdystrophin, but it failed to totally rescue the heart. It rescued the skeletal muscle, but not the heart. A number of parameters were still abnormal. And then he put in an even larger construct transgenically, and that did rescue the heart. And this is instructive because this is exactly what Becker patients have been telling us all along. Becker patients have two regions where if you have mutations, it results in really severe cardiac disease. One are regions in this N-terminus, where the major actin binding domain resides, and the other is in the C-terminal region, somewhere between repeat 16 and hinge 4. And we don't know how much of this region is critical, but certainly from the work of Dongchen, you need at least to start at repeat 16 or so, and then go on. How far, we don't know. But the bottom line is the necessary regions for the heart are probably larger than what we can fit into AAV, probably larger than any microdystrophin that we can design. And that means that the microdystrophin is going to be a major rescue for the heart, for the skeletal muscle, less so for the heart, and at the same time, the patients, because their skeletal muscle is largely rescued, are going to put a lot more load on their heart. So this sort of raises the possibility that we're going to create an increased cardiac burden and therefore drive this cardiomyopathy that we're not rescuing completely. So the question is, if we can't really design a microdystrophin to silence these channels and to restore the cytoskeleton and the organization of the membrane in the heart, then is it better to try to address the calcium handling and the mitochondrial dysfunction in the heart than to worry about the microdystrophin? I mean, the microdystrophin can give you some benefit, but you need to do something else. And so that something else, and this is what we're currently exploring, is you can use gene therapy to try to restore the normal calcium handling in the heart. And that might be the best thing you can do for the heart. And we have animals that we've treated, and I'll tell you right now, their cardiac function looks normal at a time when it shouldn't. And they've actually improved since we treated them. So we think maybe this could be the right approach to augment microdystrophin therapy, or maybe as a monotherapy in the hearts of Becker muscular dystrophy patients, and even in Duchenne patients, if the goal is to try to treat the heart. So the bottom line is, in the short term, we think drugs that could raise PKG activity levels, such as PDE5 inhibitors and other drugs that could activate PKG, could help as a monotherapy, because we think it will slow the dystrophin-deficient cardiomyopathy. We think it could be also used in combination with microdystrophin, because the microdystrophin is not going to completely rescue the heart. But we think long-term, the best approach is to develop a separate AAV-based gene therapy for the heart to deliver genes that can correct the calcium dysfunction, and either in combination with microdystrophin or without microdystrophin could potentially rescue the cardiomyopathy associated with Becker muscular dystrophy or with Duchenne. So that was my concluding slide. I thought I had an acknowledgement slide, but it's not coming up. So I would like to acknowledge the support for PPMD to let us pursue this hypothesis to see if we can develop a successful cardiac gene therapy for both Duchenne and Becker muscular dystrophy.
Thank you very much. Yeah, thanks, Lee. That's really terrific. So I have a couple questions for you and Kan as well. So first of all, Lee, as you can imagine, in the community, the failure of in terms of skeletal muscle of the Lilly study of tadalafil has been really puzzling and frustrating. So why do you think the skeletal muscle failed, and why, or do you think that this and perhaps another drug might be useful in treating the heart at this moment, in addition to what we're using inhibitors?
We have to remember for the skeletal muscle, the tadalafil was only going to be useful if it could increase blood flow when the skeletal muscle was exercising. So, I question the extent to which the boys in the trial really were exercising in the sense that, blood flow would be compromised to the skeletal muscle, because, their ability to walk was compromised, and so the ability to really do what we would consider exercise was probably minimal, and therefore a minimal target for the drug to try to rescue. The other, I think you could see some trends toward better arm function in some of the boys, but that wasn't really one of the trial's outcome measures. The outcome measure was whether you slowed the progression of disease in the skeletal muscle, and clearly disease in skeletal muscle was being driven primarily by things other than blood flow to the muscle. So the drug may have been able to increase blood flow during exercise, as was shown in the hand muscles, but it was irrelevant as far as slowing the disease in the leg muscles in the boys at that age. Now, the cardiac muscle is a different story. The target should have been there, and so if it had been an outcome measure of the trial, it potentially would have been possible to show improvement in the cardiac muscle, but the boys are young enough that you would have had to have made strain measurements, as Kan said, because it's prior to their having ejection fraction problems. And so the correct sort of observations weren't made to know whether or not it was providing the cardiac benefit that you might have expected.
Okay, thanks, Lee. But do you think, as an outcome measure, if the FDA would accept strain, do you think that for you, Lee and Kan, would that be predictive? Do you think, with your natural history study, Kan, do you think that this could be an outcome measure in a drug specifically targeted to the heart?
Yeah, so I can answer that first. I think strain has been used in all kinds of disease. So it's been slow to coming into clinical practice, partly because the technology has continued to evolve in multiple ways of looking at strain. So it's important on how someone looks at strain. I think some techniques are not as good as others, but I think I do think that in many disease, strain has been shown to be abnormal early and has shown to improve with treatment. So I think I would say that it is, especially in Duchenne and Becker, when you don't really have the traditional symptoms, you need these type of earlier disease markers to assess this. And I think, I think Lee's animal studies, again, is very important confirmatory information that shows you, that you can detect this even in any setting. So we strongly believe that strain, scar and function they all come tied hand in hand, but if you want to look at early indicators, strain is an important piece.
Great, thank you. And so, Lee, as you move forward with your hypothesis to treat the heart, how do you see that coming forward? Would you combine it with a skeletal muscle approach, or would this be a single approach targeted to older patients, and if so, why?
Well, I think at this point, I would do it in addition to the whole body therapy for the skeletal muscle. I do it at the same time if the individual is undergoing that. But it could be a monotherapy for Becker patients, especially the subset of Becker patients that have a more severe cardiomyopathy than they do the skeletal muscle disease. I think it could help those patients tremendously. And also, it could be a therapy to rescue the heart in older Duchenne patients if they're no longer candidates for whole body skeletal muscle delivery for whatever reasons. One could go in and just deliver to the heart. I mean, ideally, in a Duchenne patient, you would want to do it at the same time you're doing microdystrophin for the skeletal muscle, But if that's not practical for whatever reason, then I still think you could try to rescue the heart using this approach, and certainly do the same in Becker with this approach.
Great, thanks, Lee. Kan, one more question for you, and that is, as you look at the natural history of this disease and we find that strain is a marker, would you anticipate a trial? I mean, given the change over time, right, in terms of years, it's really hard to measure. Do you think that you would be able to be predictive in terms of be able to convince FDA that if the strain was less in a shortened period of time, say 48 weeks or 96 weeks, that in fact that did predict that the heart would be rescued or at least preserved for a time?
Yeah, so, I think it's a great question. I think when you look at markers of disease that are surrogate markers, it's always challenging because it's not what the FDA is used to seeing. I think new technology should mandate a better way to look at this, especially in this population. So we've used this in the Prevalence trial and showed that in 12 months, the strain, the strain was able to be slowed down compared to placebo. And then when we looked at crossover, the boys who were on placebo versus the boys that were on the medication already, the strain continues to be better. And this is because of a small study. We compare that to the kind of what we have all our data general population. And we just finished an aldosterone inhibition, eplerenone versus spironolactone, using strain as our main marker as well. And that also shows stability over time as well. And these are essentially supportive type therapy in patients who already have scar. So you can imagine if something that was treated earlier, who, as Lee said, can impact on, so we're at the mercy of some of these medications that may or may not directly affect the muscle the way you hope it would be. I think there are two things when you do trial. One is, does the medication work? Number two is the technique that you're using to assess efficacy, is that good? So I think strain to me has been a really important piece to detect early disease. It's more sensitive, and it's less impacted by many of the loading condition that ejection fraction is at risk of.
Thanks, Kan. And Lee, are you seeing strain in your animal models as well?
Yeah. We see improvements in the strain, even similar to what we saw with tadalafil, or maybe even a little better, at least in these early animals. So it's still early days for those studies, but hopefully that will carry on and will preserve both strain as well as preserve later ejection fraction.
Good, thank you. Well, it is now 3 o'clock, and we're even a few minutes over. I wanted to thank May Ling. I know May Ling Mah had to leave, but thank you, Kan. Thank you, Lee, for doing this. The heart really matters for all of us in so many ways, and I think that I guess I do have one last question that's really been nagging me. We're seeing sometimes these young boys who are having sudden death, right? And I'm wondering if you had any thoughts about how that happens.
Well, in our animals, just as we're seeing in the carriers, we do see variable but persistent but consistent arrhythmias across our populations, and so it could be that, Kan can weigh in on this, but it could be that because of an unfortunate sort of positioning of the scarring, that you can trigger arrhythmias that could be life-threatening.
Yeah, I think that's a great point, Lee. And I think as you know, there are patients who come in with these acute pain. So there are acute events that's happening. I think the boys who you catch early that present with acute pain and you see this, we see troponin skyrocket. So there's an acute injury for that, and it's unclear exactly what it's from, to be honest. But there is an acute injury that can lead to significant dysfunction, and then a really sensitivity to something that's happening with potential creating this arrhythmia pattern. So this may be slightly different than the older patient with a little scar. With there's a registry that our institution nationally is also looking at. So I think that is an important piece. That is there is something to it that I don't think we don't quite understand. But there are probably some acute injury and some arrhythmic risk that is playing a part in why some of these boys who really don't have a lot of scar, normal function, and then will just unfortunately pass away.
Thanks. Thanks very much. I worried about arrhythmias as well. So to both of you and to May Ling, please extend my thanks to May Ling. Thank you both for joining us. Thank you all for joining us on the phone. I know this is a busy season, but your participation in these webinars matters a lot to us, and we're really grateful. Have a wonderful holiday season, and thank you so much.